is that there's just more work to be done to get to a point where we feel like we're doing enough to address the need for increased diversity, equity, and inclusion, and to make a dent in health equity and access issues that are even more prevalent in this rare disease community. So today we're going to talk about some things. I love, obviously, talking about this because I think it always leads us to progress and to discourse that's useful on this topic. I will say, and I always acknowledge, this kind of work and these conversations can be uncomfortable, but they shouldn't be. If we don't talk about them and address them openly, then none of us can learn, and we all stand to learn from one another and to be in a position to strategize on how to do better in this field. So I'm going to walk through a couple of topics and then take it into health equity and access and how it affects our population, our rare disease population. And then after this small segment, we'll move into our industry partner updates. And we won't have very much after that. So the DEI journey, diversity, equity, and inclusion. We know these are buzzwords. And at the onset of the pandemic and after, certain things happened in our society, specifically after George Floyd and other things, a lot of organizations and corporate entities took a harder look at diversity, equity, and inclusion initiatives. I tell you guys, I will say that the organizations that did really well in this space, they did these things. They assessed where they were. If you see here the acronym CQ, that stands for cultural intelligence. So it's like IQ, but cultural intelligence. They assessed where they were. They explored possible solutions. They put those in place, implemented those solutions. They have since then begun to measure the impact and outcomes of the work, and they've put things in place to sustain the work. This was the model that, many organizations embrace to really dig in and to try to make a difference and have a bigger impact with DEI. Unfortunately, what you may be noticing now in other organizations, whether they're nonprofit organizations like ours, or they're industry organizations or healthcare facilities or corporate entities, is that a lot of this is being rolled back now. Unfortunately, a lot of organizations didn't commit to this particular DEI journey. They did what we call performative work, and we'll learn about that. But they put some Band-Aids on the situation. Some of them may have put out a DEI statement. If it was your organization, don't raise your hand because we're recording. Just keep your look the other way. I'm sure it wasn't yours. They did some little things to address this, but they weren't really committed to long-term impact. And so what's happening now is in a lot of the organizations that didn't dig in, this work is being rolled back. And so you'll see where they previously had positions dedicated to diversity, equity, and inclusion. They might have had a chief diversity officer in place, or they might have had program people in place. They're starting to eliminate those positions and to performatively roll these tasks into other people's jobs, existing roles in the organization, because some of the glitter and shine of this work has started to dissipate. Some of the cost of sustaining this work has started to become something that organizations are not willing to continue to invest in. And so you'll see that. When we say performative, what does performative work in diversity, equity, and inclusion means? Those are the people that put up a DEI statement and felt like they checked the box and they move forward. It is defined as an act of outwardly demonstrating support without really implementing any meaningful actions to make any change. And an example of that might be back in 2020, there was a day of solidarity where everyone blacked out their Facebook profile picture. You might remember that. But if there was no substance behind those kind of acts, then it's not really considered the DEI work that we're depending on in this space to have an impact. Also, you might see in June, some people may add a rainbow to their logo or whatever in allyship with the LGBTQIA plus community. But if there's no impact or change that's happening really behind the scenes, those are performative acts. And performative acts can be very damaging to marginalized groups because they take the attention away from the real work that has to be done. And so it can give the appearance that there's progress being made and impact being made when it really isn't. And so that's the danger of that. Here's something to consider. And so a lot of our organizations looked at inclusion because it was time for it. And this is inclusion of any marginalized group, whether it be by race, socioeconomic status, religion, sexual orientation. And so we looked at inclusion and saying that we were committed to inclusion. But is it really inclusion if you invite people into a space, but you're unwilling to change it? And that's just something to think about and really consider. I will say that if we went around on the call, and we won't ask you to do that, and I asked you in your own organization, do you feel like progress has been made in these areas? Do you feel like your organization is more diverse, equitable, and inclusive? You might have an opinion on that. But the question is, if you don't belong to a marginalized group, or maybe you belong to one and not the others, if you ask those people the question as to how you're doing, how you're rating, how you're measuring up, and being more diverse, equitable, and inclusive, what would those people say? Would those people say that the environment has shifted and changed in such a way that the inclusion is legitimate? And that's where we often fail in this work, that we have performative acts, we all sign on to them and feel good about them, but we don't always circle back to the people that we claim to be including to find out if the environment and the circumstances have really changed or been altered in their viewpoint. So here's a look at when organizations did it really, really right, what changed and what happened. I'll look at the old way and the new way. So the old way looked at possibly having some inclusion, right? We're not maybe an organization that discriminates, but not necessarily creating safe spaces. So there may have been people of color, or there may have been people who are LGBTQ. There may have been people who were in a religious minority who were allowed to be present, but there was no intention on really creating a safe space for them to work, for them to participate, whether it's a patient study, a clinical trial, whether for them to have healthcare access. The safe space was not intentionally created. So organizations that have done it really right have created safe spaces. There was tokenism. Tokenism, by definition, is just really placing someone to check the box, right? And so you may have said, okay, here's our we got a Black member of the board or the committee, or we have a gay member of the committee or the congregation, and so we're good. But that is not representative of sincere inclusion. And the thought behind that is, when you really evaluate people on their other degrees of eligibility, are they someone that will have impact? Are they someone that meets the criteria? Are they someone that will make change in this role on this committee? And then you will naturally have inclusion. But when you place people just to check the box for DEI, that is considered tokenism. So the ones who have done it right have embraced sincere inclusion. Assumptive language. And so this is the old way versus the new way. Assumptive language is very heteronormative. So we speak about things as if everyone is married in a man and woman situation. We speak about things as if everyone is Christian. We speak about things in terms of, creating this scenario where everyone fits into the box. And that's how we address things in our language. And that can be very disinclusive. And so the right way to approach this work, and organizations who are doing it well, are really looking at their language. They're looking at their vernacular in their brochures, on their website, in their emails. Is it something that would disinclude people who don't conform to a certain majority way of living life? I had someone in a leadership position say to me, interestingly, once, it was on Good Friday and we were working, and I told Chevelle this story, and I shared it with Octafarma last week. And it was Good Friday, we were working, and right when we got off of the Zoom, the person said to me, "So, do you serve the risen Savior?" And I said, I kind of laughed. And thankfully, I happen to serve the risen Savior. But what if I didn't? What if that wasn't my practice or my belief system? Because in that instance, I would have been made to feel disincluded. And so even though we may be very well intentioned as we talk to people, we really have to be careful to make sure that our language and our communication is very inclusive. Tolerance of intolerance. And that means, have you as a person, have your committees, have your leadership team taken a stance against people who are not willing to embrace DEI initiatives? Are you willing to put a stake in the sand and say, we will not work with organizations who are racist and misogynistic? Are you willing to put a stake in the sand and say, we will not tolerate the intolerance of any other human with which we relate, because doing so means that you have moved into the new, really true work of DEI. That may mean that companies lose money. That may mean that organizations lose partnerships. That may mean that you can't work with the vendor that you previously used to coordinate your patient study. But are you willing as a human and as an organization to put a stake in the sand? Under-resourcing versus prioritizing. This is where we are now with society kind of rolling back the DEI prioritization. So are you prioritizing it? Are you investing in it? Stereotyping versus changing the narrative. This happens to all of us. It's a part of unconscious bias. We all do it. I do it. You do it. But are we making concerted efforts to change that? I was at a conference not too long ago, and there was actually a member of the FDA that was on the panel. And she was talking about communities of color, and she equated communities of color to being urban, to being poor, to being under-resourced, underprivileged was the word she used. And that's a stereotype. Not all communities of color are the opposite of affluent. And so we want to make sure that we are changing the narrative in our thoughts and our thinking. And in order to do that, we need to embrace other ideas. Is there a lack of DEI accountability, or are you really looking at the results of your work? So if you started the work 2 years ago and you said that your objectives were to be more inclusive, to create safe spaces, to use better language, are you really analyzing the results of that? Or are we just saying that that's what we wanted to do, but not circling back? Are we speaking on behalf of other people and communities? Or are we really creating opportunities for them to be heard? I spoke the other day at the Mallinckrodt advisory committee, and I said, oftentimes you'll have people speak on behalf of communities, but that's because we're not really hearing from them, because we haven't created the safe spaces for them to step forward and to communicate. Are we justifying behaviors, or do we sincerely acknowledge harm? One of the most damaging things to DEI, because listen, we all have work to do, but one of the most damaging things is to rely on, oh, they didn't mean it, they'd like that. I'm sure they're good people. They didn't mean the harm. We have to acknowledge the harm. And so if I'm excited because I just won the lottery and I'm skipping through the road and I'm flailing and I'm excited and I'm so happy, but in the process, I accidentally, slap Lauren across the face because I'm happy and excited. That wasn't my intention, but it doesn't take away the harm that she's experienced. And so we have to acknowledge the harm and stop making justifications. No one is ever saying that these things are done with malice. They're done, intentionally to harm or to hurt people, but the harm doesn't disappear because of the intention. And then lastly, are we moving from the status quo? And are we committed to swift and meaningful change, even in the face of people not being receptive to that? Okay, you all seen this before. It's all about health equity and health disparity. And we're looking at health disparity, specifically in what our work that we're doing here considers racial, ethnic, religious, and other marginalized groups. And how are they disproportionately affected by disease, death, and disability? And so you'll hear the terminology equality versus equity. Equality is you give everybody the same thing, right? Everybody gets the same thing. That doesn't always create the opportunity for everyone to succeed, as you can see illustrated in the picture. Equity is different. Equity means that you give everyone what they need to succeed. But the goal is neither of those things. The goal is liberation. And liberation means is that we work together to remove the obstacles and to remove the barriers, to level the playing field so that we don't have to give anyone anything additional or extra, but we remove those systemic and structural obstacles so that everyone can be successful. So health equity means that everyone has the ability to attain his or her health potential, and that we don't allow what we call the social determinants of health, you all know that, to affect someone's ability to obtain quality health care, to obtain inclusion in clinical trials, to obtain access to drugs, education, and better treatment. And health inequities, this is why this is so serious, because it's reflected in length of life. People are dying of unnecessary disease states, severity of disease, and of course, access to treatment. And here's just a quote. It talks about how disparities and biases really reflect the inequities of society. And so we have to believe that if we live in a society that's not equitable, that also translates into our health professional arena and world as well. It's not like the world changes because we have rare diseases and we're ill and we're helping patients. It's a microcosm of our larger society. And these things are historic, and they aren't going anywhere anytime soon. We all agree to the structural nature of the problem here. But as we continue to chip away at it, we can make some really great strides in this work. So health disparities driven by social and economic inequities that are based in racism and discrimination include all kinds of things. This does not apply to every community of color or every gay and lesbian community or every non-Christian community, but we know that racism and discrimination shows up in disparities in wealth, in housing and location, in education, in nutrition, and in the healthcare system, specifically with coverage based on ability to sustain and have gainful employment, with availability of good treatment and access to great doctors, and then also access to what we call culturally appropriate and respectful care. The respectful care issue is huge in the gender realm, in the LGBTQIA plus community. There are people whose sexual orientation or how they identify keep them from being able to find doctors at all. And so imagine being a rare disease patient and being transgendered and the amount of privilege that you lose because that's your reality. Many of these people have difficulty finding healthcare professionals who are willing to treat them. And even when they are willing to treat them, they have difficulty finding those that are able or have the education or the knowledge to show them respect. Okay. When our rare disease myositis patients are visiting with their healthcare providers or talking to you all in industry to inform studies or getting into trials, that requires a good amount of vulnerability, discussing their body, addressing mental health needs, sharing very intimately personal details. Now we want to add to that layers of disinclusion, of lack of diversity, of an experience that is highly discriminatory. And this is a reality for many patients who are part of these marginalized groups, and they have to face additional health disparities, including in addition to living with their rare disease. This looks at unconscious bias. By no means do we believe that any healthcare professional gets into that field to be discriminatory or biased. That's not what doctors do. Doctors sign up to be doctors because they're good people that want to help other people. Unfortunately, unconscious bias is something that doesn't discriminate. All of us have it. All of us walk into every situation and every encounter with every person we meet with a degree of unconscious bias. And so healthcare professionals are not exempt from that. It can lead to unintentional stereotyping. And it means that some people sometimes get different treatment, sometimes for very treatable conditions, and in turn can lead to pretty devastating health consequences. So I'm going to talk really briefly about people of color in particular, because I want you all to, number one, this is a community with which I hold membership, and also so that you all can understand some of these concepts and hopefully weave it into your work. BIPOC, we talked about that before. It stands for Black, Indigenous, People of Color. That's a fairly new term and originated in 2019. And why Black, Indigenous, People of Color? It's because that group of people, Black people who are African American, who are in America, have a different relationship to white supremacy than Black people who originate from other parts of the world or than other types of immigrants. And so that BIPOC term is meant to acknowledge that. And this says that people that fall in that category tend to shelve health. And it's because they have less privilege, and they have less privilege to prioritize their health because they're dealing with other things. And if I'm a rare disease patient and I have a rare disease, I already have a lot. Life is hard for everybody. If I have a rare disease, it's harder for me. And then if I'm a person of color, I'm also possibly dealing with other societal effects that give me the inability to prioritize my health. There are stigmas in communities of color, and it leads patients in our field to choose between faith and care. And so there's the mantra specifically in the Black community to pray about it, and not necessarily an acknowledgement that you can pray and seek medical attention. There's a push to suffer in silence. What happens in our house stays in our house. And so these things are taboo to talk about publicly. Including disease, including traditional diseases, never mind rare diseases. So whether it's high blood pressure, diabetes, heart disease, these things. And then in some communities of color, there is an equation of illness with weakness and emasculation, specifically with Black men who tend not to complain because it's equated with emasculation. Now, this says people of color face discrimination regularly. We know that, we believe that in the world, but it happens also in the doctor's office. So what is a person of color's experience when they call in for the appointment? What's their experience when they're parking their car in the garage, when they get on the elevator, when they're walking through the hall, before they ever get to the doctor's office? What is their experience like? And how does that color the trust they have with healthcare providers or with industry partners who want to help them? It does color it. And so one thing that we should also add to this is the same way the majority can have unconscious bias, people of color have it too. And so in many cases, the lived experience of a person with color tells them to be on the lookout for discrimination, to be on the lookout for racism, to conjure it up sometimes. You expect it, even when it's not there. And so that's an unconscious bias that works the other way to help participate in breaking down relationships. There's also a lack of interpreters and cultural mediators to help in healthcare settings. So are we providing interpreters? Are we making sure that the vernacular is agreed upon? Historical experiences led to distrust in the medical community. We know all of these things that have taken place historically. Last November, only 42% of Black Americans were even willing to participate in the vaccine. And as we know, Black people, just as for this example, were the ones that had the worst outcomes with COVID during the pandemic. They experienced the disease more aggressively and they died more frequently. Some of this was because they did not get vaccinated, because there was distrust in that community. Also, there are statistics that say that people of color tend to be undertreated for pain relative to counterparts. There are also studies that show with healthcare providers, they're actually from the medical school standing and beyond, there are some medical professionals that actually believe that the nerve endings are different in people of color, that they can tolerate more pain. And so therefore they are prescribing pain medication less. They are less likely to hear complaints about pain, and so pain tends to be undertreated in those communities. 50% or more medical students hold that belief about biological differences between BIPOC patients, white patients. Obviously, we know that there's a huge Black maternal health crisis that some of our sister organizations address. And then there's also religious and this is not just Muslim women. This is also in Orthodox Jewish communities where there is a lack of, where modesty concerns keep people from being able to really seek and trust appropriate care. So what can we do about it? Best practices for organizations, healthcare professionals, and you, our industry partners. And this says that inclusive organizations are trying to fix this. Okay, they're confronting bias and they're making health equity and access a core strategy. You know that if you're a patient advocacy organization, if you're an industry partner wanting to work with patients, empower patients to develop drug strategies for patients, then you have to make this a core strategy, a business strategy. And so this says that these organizations make health equity leader-driven. It's top-down. So you cannot have people who are in the programming department or who are middle management leading this. This has to be buy-in from the board of directors or the C-suite professionals in your case, or it will not manifest. It doesn't matter who's in place and who's passionate. You might be the most passionate leader around these initiatives, but if you don't have buy-in from the top, it won't be successful. Developing structures and processes that support equity, taking specific actions that address the social determinants of health. When we were on our last call, Dr. Agarwal talked about how important it was to invest in some things that could help people participate, whether it was transportation or supporting them with technology or whatever the case is. These are very low investments to make sure that when we're doing clinical trials and we're having our results, that they're inclusive and diverse. Confronting institutional racism within the organization. This is putting a stake in the sand, saying as an organization, as people, as individuals, what we're not going to put up with. And then lastly, partnering with communities of color and creating spaces for them to lead this work. Lived experience is important. This is why I make it a priority for me to talk about this, because you may have other leaders who aren't in a position to lead this work or don't feel comfortable. I will tell you.